Next panelist, Dr. Helen Yun, practicing in Hackettstown, New Jersey. And again, I met her 4.5 years ago. She started learning MIS, but now she's queen of MIS, and people fly to her, have her perform MIS cases. And I'm so proud of Helene, and she's now one of our team coaches in our academy, consulting academy. So, Helene, without further ado, could you please share your case studies and your take on MIS on the Hammertoe?
Sure. Hi. Good evening, everyone. So just a little bit before I start my case study that TJ want me to share about common procedure in MIS, and which is what we see every day, which is Hammertoe. Just a little bit about myself. I've been in practice for 18 years in Hackettstown. I went to New York School, Podiatry School, and I stay in East Coast. Why I stumbled into MIS, I always very intrigued about the small incisions surgery, even got trained in open surgery. I tried to make my bunionectomy incision as small as I could. But of course, it's when I see TJ's lecture and webinar about MIS, and that's back into 2018, that's when I got very interested and become involved in his program. With MIS, that I found very not just about the financial part of the practice, and as well is for us, what we do, what we got trained to do is to help patients. And when we have seniors or patients with comorbidity, when it comes to surgical correction, to help them walk better, improve their life activities. And if this involved with their comorbidity, that's a limitation of what we can do with traditional open procedure. And that's what I found. MIS is kind of fit into that, that realm of helping the patient and be able to transform what they can do with their feet. So my oldest patient I operate on is 105 years old with MIS. The youngest is 5 years old. So most of the time when we see an older patient populations, and we see them with corn, hammertoes, bunions, and other foot problems, just like what Dr. Shea discussed about the exostosis and painful, we tend to see very shied away of performing procedure because it's going to need to go under anesthesia. Are they going to be a good candidate for any implant and that sort of thing? So that is kind of put a stop on us and slow us down in terms of like how to provide the proper care for the patient. We kind of stop right there, and that actually is very bothered me. And ever since 2018, I've been able to help so much more of the patient who are not traditional surgery candidate now become the patient that I can help with MIS. So just a few cases that I did in my office. I'm going to start out with a mild case of hammertoe deformity. So this patient, she has, it's a combination of hallux valgus and deviated digit. So if you look at the on-weight bearing x-ray, let me see if I can play on the screen right here. So when the patient off-weight bearing, you see it's not so bad, but on-weight bearing, look at that, it's completely deviated. And on her left foot is actually have her bunion corrected, but the hammertoe wasn't corrected because of her age. She's at 71 years old. She have history of cardiac issues, so sedation, anesthesia wasn't clear for her to go through under anesthesia. So she never again back to the doctor because there's nothing that they can do surgically for her. So she just have to live with it. Very painful on the joint when she walked, because you saw how deviate everything from the MPJ to the digit level. So have a hard time finding footwear. And so that she came to see me, and how I approach with her foot, we're going to start with the right foot, since that the right foot has been really bother her. So I did a procedure. She's not a typical hammertoe deformity. It's just a deviated. So what I did a procedure to correct the bunion, which is we're not going to discuss in this little time that we have. So what I did a soft tissues, like what Dr. Larry Bass mentioned, a very aggressive soft tissue, because you see how laterally deviated on all the MPJ 2, 3, 4, and 5. So I did the procedure with the lateral release, capsulotomy, and the tenotomy as well. And I make the incision. I'm not sure you can see my cursor here. The incision on the base of the proximal phalanx. And that is how the basic, there you go, right here. So if you see right here, that the base of the proximal phalanx, I make the incision of the osteotomy on the base 2, 3, 4, and 5. Actually, 4 and 5, I just did the tenotomy, Dr. Larry Bass. So, all the soft tissue correction. And on the 2, 3, and 4, I did the osteotomy on the metatarsal osteotomy in the head. And it's a little bit different what I learned between open surgery while osteotomy compared to MIS, DMMO, is actually the position of it is a little different. That it will let me be able to maintain without using any of the hardware. And the technique that we've been using and performed between Dr. Larry Bass and Dr. Tim Shea, along with my colleagues in MIS group, that we don't use any of the hardware on all of our procedure. And that is such a game changer in the patient, save them financially, but also helping them with clinically as well, that they don't need to deal with the hardware. So that's what I did. And how it came out, you see that this is the portal, the skin incision that I made. That is all. I didn't need to use any of the suture at all for this patient. A small incision can get me to make the osteotomy on the metatarsal area and the base of the proximal phalanx. And same thing, and a few months later, the patient is so happy with her results, and she wanted me to take care of her left foot, and that I did exactly the same thing on the left foot. For the left foot, because the patient has been corrected before with the with the screw, the orthopedic screw here. So I only need to do the Aiken to correct her deviation of the hallux. But very simple techniques that we just make the incision on the bone on the base of proximal phalanx. Another case I have, this is halfway bearing. Very important about minimal invasive or MIS technique that we're doing is because we don't use hardware. So the splinting is such a crucial in this part of the process, and that is how my post-op splinting and taping on this patient's feet. And usually that's go between 4 to 6 weeks with the splinting, sometimes a little longer. It depends on how severity of the condition. And that's how it is. That's how it is, like 3 months post-op, and that is 2 years post-op on the right. So this is a 2 years post-op. This is 3 months post-op. I tendency to follow up with my patient up to 2 years, and if the patient's still around, I usually just check in with them, see how they're doing. And they so far, ever since I started with the MIS journey, I haven't had really much of recurrence with my patient due to the techniques that I'm doing. This is another one with the contracted hammertoe that we've seen pretty common in our practice. This is a very active male. He's a runner. So his digit is very contracted, and he not be able to continue to do running because pain on the metatarsal area, pain on the arch. He had one of those typical like metaductus kind of like foot type. So correction wise, it's always a challenge. But what we be able to do, that I be able to relieve the tendons, contractor, and the capsule through the MIS technique, the capsulotomy and tenotomy, and correct it at the base of the proximal phalanx as well. So as you see from the x-ray, this is the osteotomy that I did. I didn't need to do any further osteotomy on a different bone. It's just on the base of the proximal phalanx, along with the tenotomy and capsulotomy. This is where my portal. still no suture. And this is how I splint my toe, the patient's toe, splinting with taping. And as you see, this is how it is afterward. Patient is happy, get back. And talk about the little bit more severity of the hammertoe. So I've been having a lot of patients who came to me because of the crossover, what we call the deformity. This patient is actually, she's 50 years old, but she have a severity contracture due to rheumatoid arthritis. So a typical rheumatoid arthritis joint, a very debilitated patient. She's constantly having lesion broke out in her skin. So it's not just for cosmetic effect. And this particular patient is more like limb salvage, as well as, prevent the patient for the breakdown on her with her condition. So as you see, bilateral crossover toe, very severe hallux valgus, completely dislocated of the MPJ level. Okay, so this is here. Right here, as you see, is like, typically we would just remove all the metatarsal head. That is what we would normally do, but it's not the case in this time. So what I did, similar to what I did in the proximal phalanx, on the osteotomy on the base of the proximal phalanx. So I'm going to move very quickly here. So as you see, right here, this is my portal because of her bleeding through her taking medication. So I need to do the suture. So I correct the hallux, first ray, second ray, third ray, fourth ray. So the second ray, because of the crossover, I need to make the incision on the head of the proximal the head of the metatarsal area to be able to get the patient back in the correction. Same thing with the right foot. And that is the after result. Patient's happy, be able to get back on her foot with footwear, whatever footwear that she has. Lesion is continue to off the pressure area. So those are the three cases from the mild to severe deformity of the hammertoe. So just a brief case like that, when we come in with the case, this severe of deformity, most of the time we're very concerned about the patient and how we're going to correct it effectively. So this is shown that MIS is possible to help this patient get back on their feet. She's 50, she's still active. She'll be able to do what she wants to do. And this is what we got trained to do. This is what we, kind of like our calling, what we hear in the group of like more than 50 doctors, right? We do this every day. There's a reason why we do this. And I think I'm considered one of the youngest doctor in our group that in joining and very inspired by Dr. Larry Bass and Dr. Tim Shea. They've been through so many things, many different challenges in their career, and they be able to convert into MIS. So there is something is very out there, and it's be able to help us to help patients. So that is one of the skill, and I'm very happy that I met TJ and be part of his program. And for our upcoming July event, and that is something I strongly encourage everyone on this call, try to, if you something kind of like wanting to do something to continue to help your patient, this is a place to be. It's an event that you're going to see so many happy doctors. Not a lot of complaint about the money, about the outcome, about insurance. So, I never been to such a conference or a gathering of doctors who very happy with what they do every day. And I will be part of the instructor, so I will be there. So, just reach out and I'll be more than happy to share my experience with everyone. Thank you, TJ.
Thank you so much, Aline. Awesome. So those are the three simple MIS procedures you can start with. Soft tissue procedure, exostectomy, and the hammertoe, procedure. And let me see how many of you are brand new to MIS. If you're brand new to MIS, just put number 2. Number 2, if you're brand new to MIS, that you haven't really performed. I want to see kind of client like college clientele right now. All right. So some 2s coming up. Okay. If some of you Okay. Yep. So again, you're not the only one. I mean, I see doctors who are great open surgeons, but really not have been exposed to real MIS procedures that we perform. All the procedures we perform, and I helped other doctors are proven ones that have been published, so that if something goes south, you have articles and you have studies already done, so you're not someone who's just kind of inventing procedures. These are proven to be effective. If you have been doing some MIS procedures, type number 5 in the chat. Number 5. All right, so then I'm sure you guys will be interested in doing some little bit more, osteotomies, lesser med osteotomy, bunion, procedures, reverse Austin, revered denation, some midfoot procedures, calcaneal osteotomies,